Good morning, my name is Breda Lynch. I'm a consultant in clinical microbiology in the Mater Misericordiae University Hospital in Dublin in Ireland, and I am the lead for antimicrobial stewardship in my hospital, and the title of my presentation today is Implementing beta-D-glucan testing, one test, multiple benefits. These are my declarations. So the outline of my talk, I'm going to discuss our aims for repatriating BDG testing, the guidelines, recommendations and evidence for BDG, our implementation process and the results and conclusions. Beta-D-glucan, as you know, is considered the pan-fungal marker. It is a cell wall polysaccharide of Candida, Aspergillus and Pneumocystis jirovecii, but Mycology molds are the exception. So beta-D-glucan can be excreted into the blood, tissues or other bodily fluids when fungi are growing, except in Mycology molds, and this can be detected on this test. Of interest, the high negative predictive value of beta-D-glucan testing makes it an attractive antimicrobial stewardship tool. So our aims for repatriating BDG in our hospital was primarily to improve patient care. Firstly, we hoped that outruling fungal disease in at-risk patients would allow empiric antifungal therapy to be stopped, and as we are well aware, much of the empirical antifungal therapy can carry significant side effects. Also, by improving the diagnosis of a fungal infection for patients, we could promote earlier targeted therapy. Next, we aim to improve the turnaround time of BDG results to less than 3 days. Prior to implementation of in-house testing, we were sending tests externally abroad and there wasn't electronic results available, so we were waiting for hard copy, which was delaying the turnaround time to result. Next, we aim to reduce the costs for the hospital by both performing the test in-house, which should work out cheaper, and also stopping unnecessary antifungal use. And finally, we hoped that beta-D-glucan testing would promote antimicrobial stewardship in the hospital. So I will briefly discuss the guidelines and recommendations surrounding beta-D-glucan testing, but it is important to highlight that the majority of the guidelines discuss a photometric or colorimetric assay, so such as Fungitel. They don't really look at the turbidimetric assay, WACO, which is what we introduced into our laboratory. And this is because up until recently, the Fungitel was largely used across America and Europe. So the IDSA Clinical Practice Guidelines from 2016 recognise the utility of a positive beta-D-glucan for the diagnosis of invasive candidiasis, and also recognise that it has a high negative predictive value. The American Thoracic Society Clinical Practice Guideline from 2019 is very interesting. It recommends that in critically ill patients, the clinician doesn't solely rely on the serum beta-D-glucan for outruling invasive candidiasis. However, they do recognise that the beta-D-glucan has utility when combined with clinical risk determination and microbiological data. This is extremely important in our context, as when we implemented beta-D-glucan testing, it was predominantly ordered by either a consultant clinical microbiologist or an infectious diseases physician, so a very controlled scenario. Of interest, as an aside, this paper also raises the question, does beta-D-glucan triggered empirical antifungal therapy actually improve clinical relevant outcomes in the critically ill patients in critical care? And we don't know the answer to that question. 2 guidelines discuss beta-D-glucan and its utility in the diagnosis of invasive aspergillosis, both the IDSA guidelines and the 2017 ECMID, ECMM and ERS guideline, and they recommend it is a useful tool in these scenarios. The EASL guideline from 2016 recommends the use of beta-D-glucan as a contributive laboratory diagnostic tool for PCP diagnosis, and again highlights its utility as an antimicrobial stewardship tool with the high negative predictive value, excluding PCP in these settings. So this very interesting paper looks at comparing Fungitel with WACO. So as previously mentioned, Fungitel is a colorimetric assay and WACO is a turbidimetric assay. The reason why we installed WACO into our centre is because of its multiple or single sample use. So our centre wouldn't have a very high number of beta-D-glucans being undertaken daily. So to make the Fungitel or a similar assay cost effective, you would have to batch tests and then run them together, and this would delay the turnaround time and delay the result to the clinician. However, with the WACO, you can put on a single sample or multiple samples, and then while they are running, if you get another sample from a different patient, you can add that on to the run as well, and then you get a result to the clinician within a few hours. And now to discuss our implementation process. The first step of implementation was in-house validation of the WACO assay. So we used both sera from patients that had beta-D-glucan organised for external testing and also from patients not suspected of having a fungal infection for true negative. And then we clinically interpreted the results in context of the patient, all their other investigations, and then compared with the external laboratory result as well. Now, it is worth noting here about the sensitivity and specificity of the assay. So the manufacturer's guidelines suggest a cutoff value of greater than 11 picograms per milliliter. However, as other centres have done, we decided to lower the positive threshold to 7 picograms per milliliter as a positive result. So in doing this, we were increasing the sensitivity and the negative predictive value, but in balance, reducing the overall specificity of the test. And we did this as we were confident that the test would be organised and ordered on patients under the care of clinical microbiology or infectious diseases, so there would be diagnostic stewardship around how the test was being ordered. So how we did this was we have daily multidisciplinary team meetings in intensive care. We have 3 weekly multidisciplinary team meetings with the heart and lung transplant physicians and a weekly MDT with the hematology physicians. We liaise frequently with oncology, but not on a scheduled basis. And then those patients with HIV or AIDS are primarily under the care of infectious diseases. Within these control settings, these are the algorithms that we designed. So they are designed to outrule invasive fungal infections with a high sensitivity and a high negative predictive value. So in a patient in critical care, for example, with sepsis of unknown cause, but risk factors for invasive candidiasis, such as total parenteral nutrition, candida colonization at 2 or more sites, etc., we would initiate investigation. So send a beta-D-glucan as well as blood cultures and other microbiology related relevant samples and other investigations that were indicated. If the patient was azole naive, they would start on fluconazole at that stage. If they were critically ill or previously had azole therapy, they would get an echinocandin. Then the patient would be reviewed with the MDT either that day or the following day with that result. If the beta-D-glucan or another investigation was positive, then they were deemed to have a fungal infection or an invasive candidiasis and the therapy continued. If the BDG and other samples were negative, then we would review to see was there another alternative diagnosis that was considered at that time. If there wasn't, we would then repeat the beta-D-glucan and review the patient again with the other results. If there was a better alternative diagnosis, we would stop the antifungal at that stage. A similar process was put in place for review of patients with an infection and risk factors for invasive aspergillosis. And similarly, in patients with an infection syndrome significant or concerning for PCP, then these patients would be reviewed in the same fashion. And now to discuss our results. So with regards to beta-D-glucan and invasive candidiasis, these were undertaken in mixed population, so critical care, solid organ transplant, hematology, oncology, and complex intra-abdominal surgery. There was 107 tests undertaken between 10 months between February and December, and the majority were under the care of clinical microbiology or infectious diseases. For the purpose of this presentation, I retrospectively reviewed the results with the clinical notes and laboratory and radiological investigations, etc. So the results are here. Of the 107 tests, 42 were positive, and of these, 10 tests contributed to the early diagnosis of a fungal infection. Of the 65 negative tests, 16 negative tests directly resulted in an antifungal not being prescribed in that 24 hours or being stopped as a result. A further 25 patients did not have an antifungal prescribed as part of the outruling of invasive candidiasis from a broader differential. Unfortunately, the negative result did not result in de-escalation in 16 cases, and there were 2 false negative cases. So the 2 false negatives were from the same patient who on day 1 had a negative test, 6 hours later had a blood culture taken from a central line that subsequently flagged positive for Candida albicans, and then the second day, so 6 hours after the blood culture was taken, had another negative beta-D-glucan, and then the line was subsequently removed. 4 days later, the line tip was sent. This did not culture Candida. However, the patient had been commenced on an antifungal therapy at that time. So excluding repeats, I would say the sensitivity is 83.3% and the negative predictive value 96.61%. With regards to the test in the context of invasive aspergillosis, there was a similar mixed population and 120 tests. Of the 120 tests, 43 were positive, and 14 of these positive tests directly contributed to early diagnosis, and we had 2 false positive results. Of the negative tests, 9 contributed to stopping an antifungal, and 43 patients avoided an antifungal. Excluding repeats, this gives a sensitivity of 100% with a specificity of 96.67% and a negative predictive value of 100%. Again, I would like to highlight that all these tests were ordered under the care of clinical microbiology or infectious diseases, so there was a large amount of diagnostic stewardship involved in these tests. With regards to PCP, there was a smaller number of tests. There was 21 tests, of which 12 were positive, so 5 contributed to the early diagnosis of PCP, 5 directly resulted in an antifungal therapy being stopped, i.e. in this case a cotrimoxazole being stopped, and 2 avoided therapy as a result of the BDG. It is worth noting that we had 2 false negatives in this patient cohort. With regards to the false negatives, there were 2 patients. Both patients received between 1 and 3 days of caspofungin prior to the beta-D-glucan. One patient received 1 dose of caspofungin prior to the beta-D-glucan, and the second patient received at least 2 days, likely 3 days of caspofungin prior to the beta-D-glucan test. And as we know, caspofungin has PCP activity. So the sensitivity in this scenario was 71.43% with the negative predictive value of 77.78%, lower than that as would be expected. Finally, beta-D-glucan was being used in the scenario of sepsis of unknown origin without a recognised risk factor for invasive candidiasis or an invasive fungal infection. Now, beta-D-glucan testing is not designed for this purpose, but it was occurring. So it is worth noting that of the 105 scenarios in which this was undertaken, there was a very small number, 6, of positive results. So 2 were taken within a day of a patient dying from sepsis of unknown origin. So we don't know if it was a significant positive or appropriate positive result in those patients. And 4 had false positives, so they were never treated for fungal infection and never went on to be diagnosed with a fungal infection. Of the negative tests, 10 contributed to the antifungal being stopped or not prescribed, and a further 59 didn't have an antifungal at all, as a fungal infection was outruled from the broader differential diagnosis. So from an antimicrobial stewardship point of view, this is very worthwhile, with over half of these tests stopping an antifungal or not prescribing. There were no false negatives in this cohort. Now we can see that 28.6% of negative results did not result in de-escalation of the antifungal therapy, so still a proportion of them were not acted upon. Other results that are of interest were we had a positive beta-glucan in a patient with confirmed cryptococcal meningitis and a positive beta-glucan in a patient with confirmed invasive Scedosporium apiospermum infection. Overall, to combine the analysis of beta-glucan, we looked at 356 tests in 10 months. 31 tests contributed to the early diagnosis of the fungal infection. 40 tests contributed to an antifungal being stopped or not prescribed directly, and this equated to €86,481 saved as a direct result of the negative beta-glucan. A further 129 patients did not have an empiric antifungal prescribed, as the negative beta-glucan outruled invasive fungal infection from their broader differential. As our hospital is the Heart and Lung Transplantation Centre for Ireland, it was interesting to review beta-glucan testing in the solid organ transplant population. So 139 of our tests were in this population, and 15 positive tests contributed to the early diagnosis of a fungal infection. 8 negatives allowed the antifungal to be stopped or not prescribed, and overall 42 negative tests allowed the patient not to have empiric antifungal therapy started at all. So in this context, the sensitivity was 100% with a specificity of 96.49% and a negative predictive value of 100%. Again, it is worth noting that these impressive results for sensitivity and negative predictive value are because there was a large amount of diagnostic stewardship being implemented in the ordering of beta-glucan testing. Finally, to come to our conclusions, by repatriating BDG testing, we hope to improve patient care by outruling fungal disease in at-risk patients, and this was achieved with 40 of 356 tests resulting in antifungals being stopped or not prescribed within that 24 hours. 129 tests contributed to antifungal therapy being avoided, and the high negative predictive value gave clinicians confidence to stop the antifungal. Particularly when this result is available within 1 day, the result can be actioned quite quickly. So these were the negative predictive values for the different scenarios. Next, we hope to improve patient care by improving the diagnosis of fungal infections, and this was achieved as 31 patients had a positive beta-glucan, which contributed to the early diagnosis and treatment of their infection. So using evidence-based diagnostics can result in earlier targeted therapy, and you can see the sensitivity and specificity in each scenario. Next, we hope to improve the turnaround time, and this was achieved with the current turnaround time now on average 1 day, with a range between 1 to 7 days, and only 21 of 259 results taking over 2 days, and this was during the first wave of COVID in March of 2020. We hope to reduce costs to the hospital by performing the test in-house, and this was achieved as it was more cost effective to repatriate the testing than send externally. Also, we achieved a cost saving of over 86,000 by stopping unnecessary antifungal therapy. Finally, we aim to promote antimicrobial stewardship, and this was achieved. I think I've highlighted that the beta-glucan test is the ideal antimicrobial stewardship tool with the high negative predictive value, allowing clinicians, be they clinical microbiology, infectious diseases or others, confidence in stopping the antifungal therapy. 169 tests contributed to stopping or avoiding therapy, but the test had benefits beyond this. So by introducing the test and increasing the awareness of it and its utility, we promoted the culture of antimicrobial stewardship. You can strengthen working relationships with clinicians when useful laboratory diagnostics are available, and it also reinforces the value of the multidisciplinary team meeting when you can discuss when the test should be used and then discuss the result of the test in the context of the patient. So finally, I'd like to acknowledge my colleagues in clinical microbiology and the microbiology laboratory scientists, as well as Fujifilm and OLM Diagnostics. I would be happy to take questions at the end of the presentations.